Okay, we have a great meeting lined up. After our executive director report, we're going to be hearing an overview from our consultants, Milliman, to go through their deliverables and their work. So it'd be great to hear from them. After that, our policy analyst, Lee Hastings, will give us a presentation on hospital payment systems. And then we have some detailed committee updates. We don't anticipate any trial proposals today, but then we're going to spend some time on federal and state policy updates and the impact in Oregon, as that would be really relevant to our future work. So with that, I would like to thank the members of the public again who have taken the time to write into the board with public comment. This month we had 2 pieces of written public comments. The first from Anna Colvin, who expressed some concern about the role of private practice mental health providers and whether or not there would be adequate communication regarding a transition to a universal health plan and how that would affect continuity of care. And then we had another piece of written comment from Max Jones. He gave us a detailed proposal for a graduated tax rate to fund the universal health plan. Encourage the board members to read it and encourage all the members of our finance and revenue committee to review his comments. He has some really interesting piece of advice in there. Great. And so next we will approve the minutes from our August meeting. Is there a motion to approve the August minutes? So approved. So second. Any discussion? Okay.
Blanca?
Yes.
John Ritchie?
Yes.
Amy Fellows?
Yes.
Michelle Glass is absent. Bruce Goldberg?
Yes.
Judy Richardson?
Yes.
Cheryl Ramirez?
Yeah.
Mary Lamar?
Yes.
Yes. Approved.
Great. I'm just going to take one moment here to say thank you very much to Isabel. The meetings are excellent. The meetings are excellent. They're really great and helpful to review. So to both me and Isabel for the minutes, we really appreciate that. And then I also want to remind the board members, this has come up a couple of times recently, all of our committee meetings have meeting summaries that are done. Those are also a synopsis of the discussion of the meetings. So those can be found on our committee webpage. If you're interested in reviewing the past meeting summaries, those are always there. Again, thanks to our staff. Okay, now I'm going to hand it over to Mimi for our executive director.
Did we have any public wanting to comment on?
Oh, I apologize. So I skipped over that part. Since we don't have any major votes today, there's no public comment. Yes. Okay.
All right, thank you. So this is Mimi McDonald, Executive Director of the Universal Health Plan Governance Board. So just wanted to lead with a few updates. First, that we have contracted with a great consulting group and Spanish language interpretation is available today. Soon, coming on soon, live today, and at all future board meetings, in addition to the presence that is already there at the community engagement and communications committee meetings. Our plan is to send the supplementary meeting materials for translation, and they'll be posted to the website after the meeting. Next, a new Universal Health Plan Governance Board member has been selected by Governor Kotek after being recommended by the board chairs to be approved by the Oregon Senate on September 29th, and after that, so our newest board member will be joining us on October 1st, so we're delighted about that. Next, I wanted to inform the board, and Isabel, do you mind just advancing? Thank you. The board and people who are participating here, that Governor Kotek sent out a letter to essentially all the agency leaders who were employed by the state, talking about, sorry, I have my glasses so I can get to the one that I can read it with. Having to do with the changes in the 2025-2027 projected budget. So I'm just going to read from the letter from Governor Kotek. This is dated September 16th. As you know, the combined impact of national policies reflected in the September revenue forecast yields a fiscal environment resulting in the 2025-2027 legislatively adopted budget, or the LAB, no longer being in balance with projected revenues for the biennium. The gap we must collectively overcome is $372.7 million general fund dollars, which is approximately 1% of the current LAB. There's a lot more to that letter. It's available online if people are interested. What that means for the very small level for the Universal Health Fund Governance Board is that there is a small budget reduction projected, and as soon as we have the details, we'll update the board and then give a full budget report. So thank you, and we'll go on to unless there's any questions. Super. I'll go on to the next slide. So again, this is from not the updated budget, just from the working biennial budget, and I just broke it out into the largest of categories. So our total legislatively not approved but adopted budget is for roughly 1.8 million. You can see how it's divided up there between.
I think you have it on the wrong
We're not
slide.
on the right slide.
That's it. Thank you. Sorry about that. So there's the working biennial budget. Again, the expenditures total of 1.8 million, and that's for the biennium, broken up mostly between personnel services and then services and supplies, with the majority of that going to our professional services. Next, also to keep everyone apprised of where we are at in terms of our consultant groups, I have the largest different groups that we have: Echo Northwest, Milliman, Wentz Jackson, which is Patty Wentz, and Artemis, which is Diana Bianco. And you can see what they are budgeted for, what the balance is, and what the current contract end date is. Some of those may be, at least one of those may be extended. That hasn't been completely confirmed, but that is anticipated. But the good news is everyone, we are certainly on track to remain within the budget and then the not to exceed, and probably will fall under budget for some. So thank you. And we'll go on to the next slide. Just very briefly, I wanted to go over at every board meeting, one of the things that we have in general policy and procedure is that all of the policies and procedures will be reviewed at least annually. So this is an attachment. This first one is general policy and procedure number 1. And so truly the proposed changes that we have, we're updating the names of board members and also their term dates, and then updating the name of the executive director. But then briefly, if you go on to the next slide, I wanted just to bring people's attention and maybe remember all of the things that are in the general policies and procedures. I didn't print it all out. It's about 9 pages. That might be a waste of paper. However, this has to do with the governance of this board and the rules that are followed. And you can just go on to the next slide too. And that all of these will be an annual review. So at this point, I'll stop and ask if anyone has any concerns or questions, or if we can get a vote to approve the updated general policy and procedure number 1.
For a motion to approve the policies.
So moved.
For a second? Second. Any discussion?
This is Mary Lou March. Since I came on in the middle of the game, there is posted somewhere, but I think policies, and we'd like to say
Posted on our website.
Yes, and it was attached. It was attached to the whenever when you go on to when the meeting is, it'll be so it's there. So it was sent out ahead of time. Yeah.
I wonder if it's useful to table approval of the policies until next meeting if people want to
Definitely.
time to review them. We had a change to our policies around the public meeting law a couple months ago. Other than that, I'm not sure, but if anyone wants to spend some time reviewing our general policies and procedures, making any recommendations for changes. We certainly could do that and defer this one until next month. So I refer, or we could vote now.
I'm okay voting.
So we had a motion and a second. Any other discussion? Okay, so we'll have a vote to approve the general policies and procedures with the updates as outlined by Director McDonald.
Walker,
Yes.
John McGee,
Yes.
Amy Fellows.
Yes.
Michelle Glass is absent, Bruce Goldberg,
Yes.
Katie Richardson,
Yes.
Cheryl Ramirez,
Yes. Yes.
Mary Lynn.
I'm gonna abstain since I'm.
And so I'm happy to introduce them. Yes, so I'm happy to introduce, we have our consultant group from Milliman. And we have the project lead, Fritz Bush, will be presenting today.
I have a comment in the chat that it's difficult to hear.
Oh. Is it difficult to hear the speakers? Let me see if I can turn up the volume on that owl. And then
Generally, it's totally understandable, but it's just a little far away, and there's a bit of an echo.
thank you, Fritz. And then Fritz, would you like to share your own slides, or would you like us to drive the presentation?
I think we will go ahead and share.
Thank you.
So give me just 1 second to do that, and we'll get started. All right, so first of all, can everybody hear me?
Yes.
Yes.
Very good, and everybody can see the screen that I'm sharing? Or not?
Yes.
You can, okay, very good. All right, we will go ahead and get started then. Okay, so first of all, on behalf of the Milliman team, thank you for having us on this project. We're very excited about it. And we are digging in as rapidly as we can. There's a lot to take in. This is an ambitious project, so we're excited to be a part of it. My name is Fritz Bush. I am a principal and consulting actuary with Milliman. I've been with Milliman about 10 years. Prior to that, I've spent most of the rest of my career on the plan side, carrier side, mostly with Blue Cross Blue Shield plans. While I've been at Milliman, I've done a lot of work on the healthcare reform side of things in various states, various initiatives. None is as ambitious as this, so congratulations on that. But I have a fair amount of background in doing this type of modeling, and so again, we're looking forward to working with you all. So we're going to be here for about the next 30 minutes with you, and we've got the rest of the Milliman team, and I'm going to let them introduce themselves. You can see them here. We've got 3 different, excuse me, teams and team leads that are supporting this project, and they're all going to walk through a little bit more of the detail of each of their work streams here in just a minute when I get done. I'll just do a short introduction here and turn it over to them here in a moment. All right, so our project scope, we were signed on to this project to really support 4 different areas. 3 of the main committees: the Plan Design and Expenditures Committee, the Finance and Revenue Committee, and the Operations Committee. We're also going to be supporting the UHB, I'll just call it the UHP team, Mimi's team, in writing of the final report. So we'll be supporting them in that. And then we have an additional report after the main report, which is an implementation plan as well. So that's really the overall scope of our engagement. And so this is how, just a visual of how we will be sort of pulling things together to, you know, as far as supporting the committees, and then each of the committees, and then the exact deliverables. The names of the deliverables are in parentheses there. So we have an actuarial modeling report that is directly supporting the Plan, Design, and Expenditure Committee. We have a report on economic modeling, and I'll go through that one a little bit more in detail here on the next slide. And then Massey will talk about that more. We have an operations and administration, excuse me, for the operations committee, we have the administrative structure and startup cost report. And then, of course, Eco Northwest is a different group, but we are working very closely with them, and will be on several items that affect, in particular, the economic impact modeling. So that's sort of an overall structure of our team. In terms of, I mentioned before that, you know, how our reports will tie together is they will be really supporting the economic impact analysis. So we will take parts of each of the other reports, the 2 Milliman reports, and then again, working with Morgan at Eco Northwest, that will all basically roll into this economic impact analysis that will have, you know, the main conclusions that will support the legislative report. I'm not going to go through this slide. You will have this for reference, but there is a little bit more detail on some of the subject areas that are available. So if you want a quick reference on that, that'll be on slide 6. The team leads are going to go through that here in just a moment as well. So I won't spend a lot of our 30 minutes on that. You'll have this for your reference as well. I'm not going to read through these. We're keeping sort of a running list of the key questions that we have along the way that will need to be answered by the time we get to the end of this whole thing. So again, this will be updated periodically, but you can kind of read through those and see sort of where we're at right now, and where we're, at some point we'll need some resolution on some of these things. All right, and with that, my part is done. I'm going to turn it over to Ken. And Ken, just let me know when you want me to advance the slide.
Sure. Thanks, Fritz. So my name is Ken Laskowski. I'm a senior consulting actuary with Milliman. I've been with Milliman for 20 years. And like Fritz, I have a lot of experience in healthcare reform markets, helping states with 1330 waivers and with basic health plans and in general pricing in ACA markets. Along with that, I also have some experience in projection modeling. My first ever projection modeling project similar to this was in 2011. I did modeling similar by market, what was going to happen when the ACA started, what was going to happen to the individual market, small group market, large group market, and how are each of those going to be impacted. So I have some experience in this area. I will be primarily responsible for the actuarial modeling portion of this project, working primarily with the Plan, Design, and Expenditure Committee, though acknowledging that my role will require a lot of communication with the economic and revenue side of things and with operations, as a number of our results between all these groups kind of impact each other. So I just wanted to go, Fritz, if you want to go to the next slide, I wanted to give a very generalized approach to how we go about this type of project and how we go about this modeling. And this is information that we presented and gone over with the Plan, Design, and Expenditure Committee already. But you know, right now we are in the first 3 phases here. We're engaging with the Plan, Design, and Expenditure Committee. There's a number of things the number of assumptions that committee is going to be developing that influence our modeling. For example, provider reimbursement structure. How will physicians and how will hospitals be reimbursed and at what level? So that's something we need to work with them and to assist them with. And then that flows into really, we need a starting point. We need to develop a baseline census and baseline expenditures. Where is Oregon right now? And we have a number of data sources that we're utilizing for this, APAC data, OHA data, and then a number of both proprietary and public data resources at our disposal. And so we are pretty deep into that already because we're also already building our modeling, our projection modeling. How do we turn that baseline into 2030 and beyond expenditures? And then once we have some modeling done, we'll really move into that next phase of communicating results, and that's really going to be an iterative process for us. So we will deliver results. They'll take some time to digest. They'll take some time to understand. Part of it is us communicating exactly why and what is driving some of those results. There may be some surprises, not prizes, surprises. And then I anticipate that there'll just be a lot of back and forth. Why did this happen? Maybe can we tweak this? So we've left some room in our timeline to really have some back and forth before we get to that final report there. So if you go to the next slide, I talked about how we're in this phase where we're building the baseline, our starting point. So right now, building a baseline, it's built by market from a number of different sources, as I mentioned, and we really think about that in terms of enrollment, who currently has coverage, and at what level, and costs. That leads into cost. So when we think about enrollment, it's we think about by geography, by income level, and by demographics, because each one of those and how they change will influence the cost to the UHP plan, and then that goes right into costs. So benefits, what is currently offered, and how will that change, and what are plan designs? So you think of something like the individual market. Someone may have a bronze plan, which is a lower actuarial value plan, and they're going to be moving into a rich plan. How does that influence costs? How does that influence utilization? And then right now we need to understand providing reimbursements in Oregon. How much are physicians and hospitals being paid? And then when you conceptualize a premium, like a starting point premium, we do have to consider what administrative expenses are currently. And what's built into admin is general administrative costs, and then things like commissions, taxes and fees, and risk margin, which may be going away with UHP, but they're part of our starting point. So then we have our baseline. If you go to the next slide, Fritz. So I want to show a chart. We have our baseline. It's our starting point. Once we understand that baseline, we really have this intermediate phase, which is it seems simple, but it's also a complex part, which is projecting to 2030. So there's there's already a lot happening this year, a lot of changes in the different healthcare markets and legislatively that are happening this year. So we need to project out to 2030. And then when we get to 2030, we really have a status quo. So a status quo scenario is being that there no UHP is implemented, which forms the basis of interpreting our results when we look at UHP projections. And so then we have room here in our projection for a couple of different I think we're looking at least two different UHP plan options. So really, in that projection going to 2030, we're looking at how is trend, how are costs changing then, how are different markets changing, population changing, or do we expect more people to be uninsured? Things of that nature. So then I wanted to go, if we go to the next slide, Fritz, just want to discuss here, how do we think about these changes? We have our baseline. What are we thinking about when we're thinking about population changes? And we're thinking about, well, enrollment changes, and we're thinking about population and demographics. So where Oregon is now versus where it's going to be in 2030 after UHP is implemented is different. There's going to be people who uh, there's be general population growth. There's going to be some people who moving into Oregon, some people moving out of Oregon. There's general, as I talked about, maybe how is the uninsured market changing? So what are the shifts in status quo? So we really need to understand. We'll really need to project and help you understand what those different changes in population are, and then if there are changes in population, how is that influencing demographics? Because demographics have direct influence on costs. So how are age and gender levels, how are income levels changing, and how and where are people moving into or leaving from? So go to the next slide. Wow, modeling changes in enrollment can be straightforward, but modeling changes in cost tends to be a lot more complex. There's a lot to think about and a lot of interdependent results from these changes. So just breaking down into 5 main areas of changes in cost. This is maybe not exhaustive. There's a long list, but we start with benefits. Think of something like dental and vision are generally elective benefits. So a lot of people don't have dental coverage, but if UHP it starts to include dental coverage, that's going to be, we have to calculate that as part of the change in cost. Then going back to that concept of plan design, as right now the UHP is using the PEP plan, the public employees plan, as the starting point. That's a very rich plan when you compare it to going back to that bronze individual market plan as an example. So how does that change costs if we move to this richer plan design? Because that leads into utilization. We think about, it's a general accepted concept that as a plan becomes richer, utilization increases. So for example, if a PCP copay in a plan is something like $40 and it goes down to say $0, that we see an increase in PCP visits as a result of that. And we have, Milliman has our health cost guidelines that we use to help value those changes, those changes in utilization. And similar concept to other aspects too, like hospital visits, surgeries. Fritz, I lost my slide. Okay. Then also in terms of utilization, there's pent up demand. Dental's one where we see a lot of pent up demand. We see a lot of first year utilization. You just conceptualize someone who has never had dental, that toothache they've had for 5 years, like they're going to go get that fixed the second that they can, if they all of a sudden get dental coverage. So that goes into cost as well. The next, provider reimbursements. We already talked about how much our physicians paid varies by market. It's the UHP provider reimbursement is going to be primarily policy driven. So just for example, if UHP sets inpatient facility reimbursements for surgery at 120% of Medicare, that is more than it's set at for Medicaid, but it's perhaps less than someone getting that same treatment from a commercial market. So how how is that going to influence costs going forward? And we'll be modeling that. Then we have to consider cost containment, and we really think about savings programs and saving strategies relative to the current saving strategies. Are they going to lower costs, keep them approximately the same? And how much will they influence it, and what degree of medical management is there? Uh, and then finally, there's just some general changes in medical and prescription drug costs that, just general trends, RX trends, prescription drug trends have been very high recently. So how is that? How do we anticipate that unfolding over the next 5 years? Um, we haven't really gotten to the details of the UHP formulary and what drugs will be offered, but that's going to influence final costs. It's going to influence different utilization patterns. So that's really the generalized view of our approach. If you go to the last slide here, I'll go quick, do timeline. Right now we're in that baseline and that model construction phase. In October, we'll really be moving to our projecting phase. Our model's built, looking at what are our different projection assumptions, with the goal of really delivering round one results by early November. And like I said, leaving room for those iterations before we get those reports out in February and March, and time for collaboration. And I'll stop there. We'll move to, unless there's any questions, we'll move to operations.
Ken. Hi, everyone. I'm Stephanie Ross. I'm part of the Milliman team. For those I've had the chance to meet at Ops Committee, good to see you again. And for those that I haven't, it's nice to meet you virtually. My background is predominantly in strategy and operations, both at payers as well as providers. And so our team is engaged to kind of lead the operations and administrative work stream related to UHP and building out both the structure, the cost, and then startup initiatives, and some critical functionalities when we think technology, infrastructure, staffing, and those pieces. So our project approach, we've been engaging in some strategic conversation, both with Mimi and team, as well as the Ops Committee. We will continue that to then design the organizational structure for UHP. That will be an iterative process, hoping to land on the formal structure here in a month or two. And then once landing on that, we will shape out the actually expected staffing roles, technology systems, and provide insight into what all those operational demands are to run a successful plan for the state of Oregon. And so once we have nailed down that exact structure and staffing and all the things that it entails, that will inform the administrative cost need, both for year one as well as on an ongoing basis, and then those startup cost of what that initial lift is. Those will segue into the work Ken and Fritz and team are doing to kind of inform the overall financial picture. And then the last thing we will do, which will be a follow-up likely next summer, is the actual roadmap and plan for implementation, knowing we're looking at a 2030 timing. So when we think about traditional payer operations, obviously with a universal health plan, those will be a little bit different, but this is how Milliman, based on our experience, typically looks at how payers conduct their business and all of the different components and things that they need to be successful. So the extent of each of these components and how heavy of a lift they are or how big the teams are, it varies depending on each kind of plan's experience or payer's experience. But what you can see, you'll see some of these items crossed out because with a universal health plan operation, we're anticipating some of these operations will not be essential, which will also ideally result in some administrative efficiency and potential cost savings by going this approach and kind of that universal structure across the entire state. And so while this is the high level of what we think about, on the next slide, there's the clicked down version of those key payer operational capabilities. And so we use, Fritz, if you don't mind going to the next slide. we use this as a basis of how we assess all plans and pairs that we engage with from all of these main kind of 9 functions, and then all of the sub functions. There's roughly 85 of those. And we have an internal benchmarking model that we can use to both benchmark against market and then do kind of an independent rate modeling build up for each of these areas when we're in a unique situation and there's not enough information to potentially benchmark, or we are building and designing from the ground up. And so this is a lot of words on one slide, but the intent of it is to help show and display all of the critical operations, critical demands that a payer has to be thinking about that will likely need to be built out. And you will see all of these come through in our structure when we kind of provide that to you later this year. To support operations, most payers need a very heavily technology infrastructure and footprint. And so we've started to think through this, knowing it's a big priority for Mimi and team. But you will see those critical areas where technology is an essential component. Claims processing almost fully rely on technology. You have some, I can keep going. Did everyone's screen go blank?
Yes.
There we go.
It should be back.
Okay. We are back. So claims processing, heavily dependent on technology. You'll have some kind of human interaction at the beginning, usually in member services or kind of customer support services, but that process is pretty automated. And given the volume of members we're looking at across the state, this will be a critical component to be considering and building out. Same goes for all of these different areas, but another critical one to think about is medical management too. A ton of data will be flowing through this work stream, and a lot of decision making can be made in this space. It will be critical to think about the system that the state decides to use and the vendor that they decide to contract with this, because not only is this one way that you kind of optimize operations, it's also a potential opportunity to kind of maximize medical spend and control that expense. So we will get into more detail on each of these and all of these systems, but we did want to share kind of at a high level what those look like. And as I mentioned, from an expense standpoint, so when we are doing this work, we look at kind of payer expense in 2 buckets. So you have the cost of care component, which is where that medical management piece falls in, provider network, product and benefit design, and then you have the admin expense. And so the work we are doing on the admin and ops structure is that side, the right-hand side of this slide, thinking about salaries and benefits, economies of scale, sourcing decisions, automation, and process improvements. And I think one thing that's important for us to note here is as payers are typically starting up, you tend to be a little bit more inefficient because you're new in this. And so while we show typically 15%, that could be a little bit higher at the beginning. But as you operate, get into different grooves, go through process improvement initiatives, design your operations to be more efficient, we typically see payers decrease that percentage. And you could be anywhere from like a 7 to 12% range. And so I think that's just an important call out of, as we look at year 1 and we're building out your model and your potential expense, don't be surprised if it's a little inflated at the beginning and then projected to decrease with time as the plan gets a little bit more efficient. And then last but not least, timeline and what we are looking at. So one of the critical things for our work stream is going to be the decision on how to operate the plan. We're preparing to have that conversation with the ops committee. And then obviously, if it comes back to the board, we are happy to come talk to you again to nail down exactly how we're thinking about operating. And then that will inform how we build the structure and determine that administrative structure. Once we do that, by end of year, we will then align on the exact kind of IT and workforce needs to then be able to build up the expenses associated. And so this is roughly our timing of what we're looking at, planning to partner and continue to work heavily with the operations committee. And then again, happy to come back to the full board and present any content needed or make any critical decisions along our journey. if there are not any ops questions, I will hand it over to Massey.
Okay, we do actually have a question sent to you.
Yeah, go right
Actually, the question is for the previous presenter, Ken, I think that was. Ken, thanks, that was really good. I think it was the astrophysicist Neil Bohr that said, predictions are really difficult, especially when they're about the future. And I think it's great we're predicting out to 2030. My question is, are you gonna give us a number or are you gonna give us a confidence range?
Yeah.
Because I know that 5 years ago, we would have been able to predict where we are today. So I'm curious about kind of ranges, confidence, how you're gonna handle that.
Yeah, that's a great question. Because if I give you one specific number, it's going to be wrong. I mean, that's just the nature of actuarial projections. So we will present. We will communicate results in ranges. So it's essentially similar to confidence interval. Yes.
Great, thanks. And we don't have these slides
No, we do, you're in your email.
in my email from
Yeah,
when?
we got them yesterday, so we emailed them out to you yesterday.
If we could get them a
Oh,
little
yeah,
bit.
and they'll be on the website, sorry, because they came in a PDF, so we couldn't incorporate them into our presentation, but then we'll put them, yeah.
Yes, go ahead, John.
Okay, I also have a quick question for Ken regarding the payments, when you're monitoring the payment systems. Would you incorporate the administrative cost saving under the universal health plan? Because provider have to reimburse on hundreds of different systems, but not it will be simplified just one system. So there's a considerable saving on the provider side in terms of administrative costs. So I wonder whether you would incorporate that.
I'm sorry. Can you repeat that? That was a little bit echoey.
Okay, my question is, in the universal health plan, considering the payment systems, would you, in your modeling, incorporate the significant saving on the provider side in billings? Because under the current commercial health plan systems, providers such as hospitals, they are facing hundreds, if not thousands, of different payment systems and coverage. But under universal health plan, it will be only one. And so there will be considerable saving on the provider side, and that will be factored into the payment system.
Yes. So we absolutely need to consider and will be considering different payment systems. That's part of the work that the Plan Design and Expenditure Committee is also doing, is evaluating and communicating to us different possibilities in terms of value-based care. We have various value-based care and different payment system experts that we are bringing in and that we will be considering in our projections. I think that answers your question.
I'll take a stab at it. This is Helen Belanca. Stephanie, I think in your presentation, you were talking about maybe planning for administrative expenses that exceeded 15% to start, but then hopefully would settle around 8 to 12%. And I think what we were under the impression of is that that number would be quite a bit lower, closer to Medicare's rate, which I believe is like 4% administrative expenses. And so I think that, our question is your estimate for the administrative expenses based on what currently occurs in the market, or wouldn't we predict far less administrative expenses under a single payer plan than under this multi-payer system?
Yes, absolutely. So I was just speaking to what we typically see in the market and what we have experienced. When we actually build this in the model, we will come back with that exact percentage, but you're spot on from an efficiency standpoint. it should be lower. I just don't want to throw that exact number out. I was speaking to what we've seen because we haven't built it in the model yet.
Okay, we have a couple other questions. Bruce, go ahead.
I don't want to speak for Chunway, but I think Chunway was asking, there's two sides to administrative costs. There's administrative costs at the plan level, which I think is what we were just talking about, the payment of claims, et cetera. But then there's the administrative cost on the delivery side. And under a single payer plan, there's a presumption of significant administrative savings on the provider side. And if I heard Chunway's question correctly, and I guess, so the question is, where and who is going to be involved with that?
That will, excuse me, this is John Casey. That administrative cost savings would come through in the rate assumptions that we would assume for the providers in your networks. And so that would be in the actuarial assumptions.
Yeah, this is Fritz. I agree with John, and the level of payment overall for institutions and professionals is a lever, so to speak, in terms of cost containment. But when you are setting those provider reimbursement assumptions, to John's point, they could be set with the idea in mind that their expenses, providers' expenses, all else equal, will be lower under the UHP.
Right, so that work's going to be done at the plan design.
Cool. That's correct.
Yeah.
Just want to be clear about where that's happening and that it will happen. Great, thank you.
This is Mary Lou Henrich of the Revenue Committee, and there's been much discussion at our Revenue Committee about this. And so this is a really important thing. We're really concerned that it's hard to know, and kind of your general data doesn't really break this out. And how is that going to be found out and understood as to what it is now, and then looking at the universal single payer plan, how much reduced will that be? So we're concerned very much on the revenue side.
Could I ask everybody to hold their mic close so that those in the audience can hear? I heard very well when you did that. First.
Does the board have any other questions before Norman continues with the presentation? Okay, go ahead, Chris.
Okay, Massey, are you ready?
Yes, sir. Good afternoon, good morning. My name is Massey Worley. I am a senior healthcare consultant at Milliman. Nearly 20 years of health policy experience. I have served as a nonpartisan legislative analyst in Virginia with the Joint Legislative Audit Review Commission, JLARC. I also served as senior policy advisor to 2 Virginia governors. So really excited to bring my state experience working with the Milliman team to think about the economic impact analysis. What I really love about this is I have a background in tax policy and healthcare policy, and these really all lie at the intersection of that. So as we first step into the first slide, you're going to notice that this framework looks very similar to Ken's first section, as well as Stephanie's. We're trying to be consistent in our approach, and I want to continue to echo that because the main goal of the economic impact analysis is to provide a seamless frame of reference relative to the other components of the analysis, and then give a big picture outlook on the effects that this change could have. So again, we are engaging with the Finance and Revenue Committee, working closely with Morgan at Eco Northwest. We've also had a great conversation with the LRO to understand the UHP and the Oregon context. We're in the process of developing our baseline economic model. This is consistent with approaches that we've discussed with those stakeholders, considering a wide variety of factors, including employment by industry, their wages, looking at the economic output and the tax revenue associated with that. We are then going to build the model, leveraging those outputs from the other work streams. And again, making sure that we're very consistent, right? We're not trying to introduce new numbers along the way. And then we want to communicate those results out and deliver a report in a really transparent way. We're going to very clearly lay out our methodology and the assumptions that we use throughout. Next slide. Again, very kind of methodologically consistent with the rate development component, whereby we are establishing a baseline, looking at the employment, both from the employee and the employer side of things, as well as the tax revenue, so that we have this existing framework to understand where folks are working now, particularly thinking about those individuals who are in the healthcare versus non-healthcare sectors. And then translating that through the individual to the aggregate employer level, and then thinking about the income tax, the corporate tax, and other taxes. Again, this is the baseline with an understanding that that helps us understand how subsequent changes are going to ripple through the economy. Next slide. As Ken was laying out earlier, we are going to develop the baseline and then walk it forward to 2030. And then from there, use that status quo as the benchmark to compare and contrast what happens under various UHP scenarios. The idea here is, again, that we want to have a consistent approach across all of our work streams. Fritz highlighted this earlier. There's going to be significant interaction and communication between the different work streams, whereby their outputs inform our modeling, so that we can provide you consistent and reliable results. I will also just preemptively state that, again, like Ken, we will be providing ranges. It is impossible for us to accurately pick a specific number that far in the future, but we can, with significant confidence, communicate how we think things will play out under the given scenarios within the context of ranges. Next slide. So as we think about how we're going to model the economic impact of changing such a large system, we're going to be thinking about how this could change utilization in healthcare, both at the aggregate level and also at the per person level. I know that there are puts and takes here. Given the relatively rich benefit plan that's being discussed, we might anticipate that utilization may go up, but there are also scenarios where preventative care could actually result in utilization per person decreasing. And so we're going to be laying those out against each other, as would be reflected in the actuarial assumptions that are being made as well. Also, I think really important as it relates to the utilization and the provider reimbursement, we're going to be looking at the need for total healthcare employment, as well as the wages that that the industry could support. So again, on the puts and takes side, there's going to be potentially increased demand for healthcare services, which could lead to increased employment. However, we also have to weigh the decisions that are ultimately made on the provider, the reimbursement side. And so that, again, will be a balance that we will strike as we conduct this analysis. Similarly, thinking about how all of this structure manifests in the revenue that is needed from the state to fund this program, we're going to be thinking about the structure of that, the total value of the shortfall and the revenue solution that will be developed, and then thinking about how that creates or alters the economic incentive structure for individuals and businesses as they think about how they are going to individually respond, but also how companies are going to respond. And so, thinking about the idea that there's going to be a significant interest in the idea of a very rich benefit plan from individuals. However, they are going to have to counterbalance that with the implications for their total compensation and taxation. businesses are going to be making very similar decisions, thinking about, okay, do we stay here? Do we grow here? Alternatively, some businesses may find the environment attractive. And so we're going to be using economic literature as well as aligning with the baseline assumptions of how the economy has grown to think about how this could ultimately produce an aggregate impact from 2030 to 2040 through the lens ultimately of these incentives combined with supply and demand. Next slide. Very similar trajectory. The way that we should be thinking about our timeline on the economic impact analysis is basically Ken and Stephanie's work streams like -1, right? So as I am being their shadow, working with them, understanding their modeling, their assumptions and their output, I will be factoring that into the economic impact analysis to then culminate hopefully by end of March 2026 with the final report. That is my basic approach. As I mentioned, I am kind of one step behind everyone else, but that means more details are to come. However, I'm always happy to answer questions.
Very difficult to hear the board members unless they're doing this. I know you said that already, but Helen's voice is coming through really clearly, but I'm really trying. Use your theater voice if you've got one.
That was great. My question is, there's going to be clearly impacts on the healthcare workforce. That always comes up as decreases, increase under this kind of a plan, et cetera. Only where is that work going to be happening? Is that part of the economic impact, or is that going to happen someplace else?
Yes, sir. So in a very hand in glove sort of situation, the overall effect on the population, as well as the change in healthcare utilization, is going to come from the plan design side, but also that's going to be reflected in the economic impact analysis, whereby we are going to have to move in concert to understand how does this change the total population, the amount of healthcare services that are being consumed, what does that mean for healthcare employment, and what does that mean for employment across the other sectors? So there's a bit of a feedback loop between these, and that's a big part of the work that we need to resolve. And just to be super clear about this, we're going to address healthcare and non-healthcare employment. Obviously, there's going to be some increased pressure on healthcare employment, but we're going to be looking on the other side to think about, okay, how are other businesses going to respond to this new offering? Again, very rich health insurance benefit, contrasting with altered incentives on the income tax side, and thinking through, based on our best understanding of actuarial and economic models and assumptions, what the literature says, how are these going to create flows of puts and takes?
Yeah, I think I was thinking about this less in terms of utilization and what the workforce is going to do in terms of that, and more in terms of, will under a plan like this and change so momentous like we're contemplating, what's going to be the response of the healthcare workforce? Are they going to flee to other states? Are they going to come here to Oregon to participate in this? I think it's a different sense of how you look at that, and wondering where and how we will also look at that kind of a prediction.
I'm following you. I think this goes back to John and Fritz's points earlier, that there's going to be some ultimate decisions as it relates to provider reimbursement relative to the simplicity that might occur as a result of a single payer system. And we will factor all of that in to consider on how we see healthcare providers coming to or leaving the state as a result of these changes.
Great, thanks.
Hi, this is Amy Fellows, board member.
I have a question if so far, or if there's a plan for any of the modeling to be informed by what we know about in other countries, we don't have another state example. And also just a reminder that we have a source here on the board, which helped create the Taiwanese universal health plan. So that's my question.
And I apologize, but I don't think anybody on our end heard most of that question. There was some static on the line. Could you repeat it?
Okay, can you hear me? Can you hear? Okay, so this is Amy Fellows. My question is if any of the modeling so far, or is there a plan for being informed by single payer or universal health plans in other nations, since we don't have another state example? And a reminder that we have a wonderful resource on our board, Dr. Chen Chi, who helped develop the Taiwanese health plan, which is a more recent one.
Yeah, I can start that, and I encourage the rest of the Milliman team to jump in. I mean, that has not occurred to us in terms of looking at. I think it's probably worth looking at, as you note. Obviously, the United States starting point and then the ending point might be different than other countries' starting points and ending points. But nonetheless, I think at a high level, it probably would be a good idea to, to take a look at that to see what types of assumptions, what outcomes that they had. So agree with you, certainly worth a look.
And Fritz, I do just want to jump in. We've actually outreached and are planning to connect with our team in London. So Milliman as a firm is global. To do some of exactly what you're talking about, Annie, and learn about their system, what they know about it, how they operate it, what outcomes they've seen. It's just one of the many examples around the globe, but I hear you, and it might be also beneficial to connect with the person you mentioned on your board as a resource to do some learning as well.
Yeah, I'm just going to jump on real quick there and say that, yeah, we've talked about this, but there is the large caveat that the underlying cost structures of what happens in the United States, even if we were to take the entire administrative system and say supplant it here, the underlying cost structure is different as a starting point in the United States. And the fact that you have surrounding states, like I think the previous question around, will providers leave the state, that kind of thing. I'm not sure it's not going to be a one-to-one match, but we're definitely taking that into account. Definitely doing that research.
John, I agree.
This is UHPGB member. Just a follow-up comment on what Annie just suggested. In terms of looking for other countries' universal health system, I think the most applicable country will be Canada, because apart from financing system, the ecological environment of this healthcare delivery is very similar with the United States. So I suggest you look into Canada's system. So for example, there have been some case comparison in terms of administrative costs, comparing the same size of hospital between Canada and US. On average, their billing department in Canada only need less than 1/10 of what it required in the US. So that would be a good reference point. And I have another separate comment and suggestions. This is regarding the economic impact. If Oregon successfully implemented the universal health system, at least 2 types of employment will lose opportunities. One is the hospital, a large clinics billing department, because we will not need that many personnel in billing department. The other will be for large employers, their human resource department. A large employer human resource department usually includes a division that is tasked to negotiate health benefit. And since there's nothing to negotiate under universal health plan, so at least these 2 types of related service personnel were lost job.
That's a fantastic point, that there are going to be private sector employees who are affected by such a large administrative shift. One of the major advantages of our approach on the economic impact analysis side is we're looking at Bureau of Labor Statistics data, and we have it at a very detailed employment level to understand their occupation. And while initially you might think of sort of the healthcare versus non-healthcare sector as being just those providers, we are trying to take a broader lens to understand all of the different types of employment that would be more or less directly impacted by this change, as opposed to those employment sectors that are going to be indirectly impacted by broader effects in the tax structure or the overall population. So your point is very well made. Thank you.
Thank you so much to Milliman for coming to the meeting, for giving us an overview, and we are thrilled to have you as part of our team. Thanks to Fritz, Ken, Stephanie, Massey, John, Kate, the whole team. We're really appreciative of your work to date and looking forward to your contributions in the future. We really appreciate you being here.
Thank you for having us.
Thank you so much.
Yes, thank you.
Have a great day.
Okay, I'm going to turn it over to Lee Hastings now for a presentation on hospital reimbursements.
Did you want me to try to wrap up 10:30 stuff?
Around 25 minutes.
All right, can you folks hear me? All right, how about now? Okay. All right, so yes, we're going to talk about hospital payment 101. This is very much a 101, so for some of you, it may seem especially basic, but I think that it's important that we're all kind of starting on the same page with respect to understanding hospitals, understanding our I think this slide is probably later in the deck, but I do just want to start by noting that we are discussing hospital payments in the context of global budgets, in part because both the Joint Task Force and our enabling statute, ORS 751, do suggest the use of global budgets when it comes to institutional providers. So first, we are going to talk about the Oregon landscape, just what kind of hospitals are out there, what they look like, then reimbursement today, and then we're going to get into what global budgeting looks like. So for context, when we're looking at the Oregon healthcare system, currently hospitals account for about 1 to 42%. We have these two different pie charts here, one that indicates the entire population and one excluding Medicare, just because we know that's kind of a tricky group. But in both instances, those outpatient costs are 21 to 22%, and those hospital inpatient costs comprise about 20% of what we see overall. So hospitals as a whole, a little over 40%, pretty significant chunk of our healthcare. Next slide, please. With respect to Oregon hospitals, we have 60 acute care hospitals. I am going to focus this presentation on acute care hospitals. These hospitals are grouped into the following three categories, and these are the federal designations. First, we have what are called DRG hospitals. We'll talk about what a DRG is. There are 27 of these. You can think of these as large, typically urban hospitals, and they're paid on the basis of diagnosis-related groups, which is what that DRG stands for. Following that, we have 8 sole community hospitals. This is a federal designation for hospitals that are rural and generally small, less than 50 beds. And then we have 25 critical access hospitals, yet another federal designation indicating these are small facilities that are rurally located, so 35 or more miles from another hospital. And what distinguishes them from sole community hospitals is that they tend to have a more narrow set of services, what are called essential and emergency services only. Next slide.
At the state level, we have some slightly different designations. Again, we have those DRG hospitals, our large and urban ones, the same 27. Oregon does a slightly easier splitting out of our rural and small hospitals though. Essentially, they say if you're less than 50 beds, more than 30 miles, you're a type A. If you're less than 50 beds, within 30 miles, you're a type B. On to hospital reimbursement. So hospital reimbursement falls into these three categories. First of all, for inpatient care, and this is care that is going to be over 24 hours, so generally requiring an overnight stay. Most hospitals are paid via those diagnosis-related groups, or DRGs. Outpatient services are paid in a sort of similar fashion, but of course we wanted to create a new acronym, so we're going to call them ambulatory payment classifications. So once again, these are kind of groups of similar services here. And then finally, separate and distinct from all that, we have our special critical access hospitals, which are paid for both inpatient and outpatient services on a cost basis. So instead of those service groupings, it's entirely based on cost. Next slide. So this is what our Medicare inpatient prospective payment looks like, or what a DRG payment system looks like. I do want to note, Medicare calls this their prospective payment system. This is prospective in the sense that if I walk into a hospital with pneumonia, the hospital knows exactly how much money it's going to get for taking care of my case. They are not getting the money beforehand, however. They are waiting until they have treated me. So that's just some nomenclature. That's how the federal government refers to it, but it can be a little unclear. So as we see, there is a base inpatient rate that is applied. These are then adjusted for each hospital based on labor and wage index. So essentially where you're located and how expensive it can be to retain or to pay your workforce for cost of living, et cetera. This amount is multiplied by that diagnosis related group, or DRG rate. So this is reflective of the amount of care and services generally needed to treat that type of condition. And this is a set amount. So again, if I walk in with pneumonia, I might have a simple case that doesn't require as much, or I might have a really complicated case. Regardless, they're going to apply that same pneumonia DRG rate. This amount can be further adjusted if you are a disproportionate share hospital, meaning you treat a lot of federally insured individuals, or if you provide graduate medical education, or if it is an especially costly case, there are adjustments for that as well. All of these different things go into a blender, and what you get is a final payment amount. All right, when it comes to our outpatient side, it's really very similar, except of course, this time we do call it an ambulatory payment classification, or APC. These are groupings of codes with that similar clinical quality needs and costs. Now, it's really these bottom two bullets that I think are the most interesting here. Just to note that when we are talking about this outpatient hospital payments, and again, outpatient, meaning this is less than 24 hours, generally in and out within a couple hours. CMS does pay separately for professional services. So when you go in, say to the emergency department, you might end up with a bill for both the emergency department, outpatient, as well as for the physician that cared for you. That is because those are two separate pieces. The other big thing to note about our outpatient payment system is that about 8 years ago, CMS did make a change regarding off-campus provider-based departments and hospitals. So previously, if you were part of a hospital but off the main campus, you could receive this outpatient rate. It switched to what they call site neutral billing, meaning that now that is not treated as part of the hospital with respect to billing. So saving the federal government some money. Next slide. And this is our graphic, what that APC looks like. As you can see, fundamentally, it's pretty similar in structure to what we get on the inpatient side. There are some slight differences in the percentage that's adjusted by wage, as well as some of those add-ons. But overall, you can get the sense what you're doing is you're taking that base amount and you're multiplying it by essentially the complexity of whatever the average complexity of your diagnosis is. Slide. All right, so apologies for the acronyms here, but again, those critical access hospitals and sole community hospitals. These are our rural and small folks, so our much smaller facilities. Critical access hospitals receive cost-based payments. They receive this both on the inpatient and outpatient side. So all that previous stuff does not actually apply to these folks. It's entirely different. This is based on information that they report in their Medicare cost reports, and applies to their inpatient and outpatient services. Sole community hospitals, in a sense, get the best of both worlds. They get to choose between the higher of whatever the standard respective payment rate or payment based on their costs. So whichever one is going to be most advantageous to them is what those folks will receive. Slide. So all of that was just Medicare. There's a reason I started with Medicare, which is that it's really kind of the standard setter for how we do. So, okay. What policy shifts, we often see that other payers, Medicaid, there's follows suit. So Medicaid follows the exact same thing. Those DRG hospitals are paid on the basis of those DRGs. They even use the Medicare rubric of that. Our rural A&B hospitals get cost-based reimbursement. I do just want to note when it comes to this Medicaid payment slide, what we're talking about here is fee for service. CCOs are free to set up their own payment arrangements. That's not something we necessarily have insight into. But on the Medicaid fee for service side, it's pretty much the same thing. Slide. Again, commercial payers, it's a little hard to know what they're doing because they're not required to publish and report everything. But we do have a pretty decent idea. We know that commercial fee-for-service contracts often use a combination of what's called a fee schedule or a percentage of billed charges. Most of these fee schedules use something very, very similar to a Medicare DRG basis in order to establish what is a reasonable fee for a given diagnosis. I will note that Oregon's Public Employee Benefits Board has recently established a limit on hospital reimbursement relative to 200% of Medicare. This is something that's known as reference pricing. It's becoming increasingly popular, where they really use Medicare as kind of a reference and then set an amount over which they're not going to pay. 200%, twice Medicare, seems like quite a bit, but in actuality, it's not too unreasonable when we look at averages in 2024. Commercial plans average 205% of Medicare for inpatient services and 263% for outpatient services. So 200% actually below average. And of course, not all commercial reimbursement is fee for service, although startling amount still is. When it comes to APMs, this is kind of what it looks like. Which is to say, not quite as shiny as I know I would have hoped for. Nearly 55% is purely fee for service still, according at least to this survey data, meaning there's just absolutely no adjustment. We then see this kind of category 2, which is close to 11%. This is fee for service with some link to quality and value. So this would be having a small percentage that is tied to reaching certain quality or cost metrics. We then have the remaining 34% that have a little bit more of those intrinsic APM value-based structures involved in them, but still pretty significant. You know, about 2/3, I would say, is completely fee for service on the commercial side. All right, so now moving into hospital local budgets. Again, here's the bit that I started with, just noting that we are discussing global budgets in the context of hospitals because it is our charge. It was also the recommendation of the task force to use alternative payments, and they did specifically call out global budgets. So what is a hospital local budget? This is a prospective predetermined payment amount generally based on historical spending with annual updates that account for population change and inflation. And I'll note that when I say perspective here, I do mean truly perspective. As in, you would receive a set payment amount, let's say at the start of the month, and that would need to get you through caring for all your patients for that following month. Now, just to put hospital global budgets in context, I really do like this, how it kind of breaks out all the different components involved in hospital expenditures. And also just to note that that arrow that you see, that's identifying where we are now, which is we use those DRG payments or DM payments. So the good news is we're not starting at zero. We're starting at step 2, let's say. We've done some work to bring some things together and to hold hospitals accountable for caring for things in a somewhat more efficient manner than it used to be. Global budgets are a couple notches down. They're the ones that are in the box there. And you can see this now incorporates not only those things that DRGs have, but it also includes some pre and post hospital services, and it would include hospital readmissions. Global budgets are not, however, capitation. Capitation differs because there you have an attribution system, which means that a patient is essentially assigned to a facility and then you're paid on the basis of those patients. Global budgets are just a flat amount, and there's not necessarily an accounting for the number of patients. Please. So here are a few different examples and just a few things that I want to highlight across these 5 different examples. I think the key ones are actually towards the bottom here, where it says specialist care included. Maryland, which is our only example from the United States, of course, does not include specialist care as part of its global hospital budget. However, all of these other countries do include that specialist care, meaning they're not going to get a separate bill after the fact for the physician that saw you in the ED. I think another key thing to note is that very bottom line, percentage of payment under global budget. While there are a couple that are very close to 100, Maryland being one of them at 98%, a lot of them are actually a pretty interesting mix, where you have some portion under global budget and the other portion is what they call activity-based, which is a nice way of saying it is still market-based. You are still being paid based on who comes in your door with the different diagnoses. So there is quite a wide range here. To save time, I did just want to focus on Maryland. We also, me and myself, had a wonderful opportunity to speak with folks at the Rate Setting Commission in Maryland. It was fantastic. It was a lot of great information. But the Maryland example is telling because it is part of the U.S. healthcare system. So it does have a lot of those same kind of built-in challenges that we're going to face. So all of Maryland's hospitals, from their community hospitals to academic medical centers, have operated under global budgets since 2014. An important thing to note is Maryland does not make access hospitals. Also, if you've ever lived on the East Coast, you'll know that East Coast rural is very different from West Coast rural. That is something that we discussed with them. So there are a couple key differences to keep in mind. Their initial budgets were based on revenues from the previous year, with accounting for all those kinds of typical things: service mix, population served, and uncompensated care. I will note, and this was also part of our conversation, Maryland does have an advantage. They have been doing hospital rate setting since the 1970s. So with respect to having revenues that were considered to be fairly reasonable, and not to disadvantage any hospital by being based off the previous year, they did have a leg up in that respect, because this was something that they've been monitoring and had control over for decades before establishing global budgets. Their global budget covers services that are at the hospital, but it does not include physician care. I will note that although they stated at the time, it just wasn't really feasible for them to include physician care, if this was something they were going to build now, that's something they would like to include, which I thought was pretty interesting. Their global budget does include allowance for capital expenditures. Essentially, if you pass the certificate of need process, you can apply for some extra funding. Otherwise, those expenditures need to be funded out of whatever revenues you have. But to the extent that there is a legitimate need recognized by the state, there can be additional funding secured for that. It's done quite well. It's held hospitals coming below national averages and benchmarks. Recently, some non-hospital spending, especially around professional services, has increased. But for the first several years, and even now, it's continued to do quite well. And I think this last point is part of why they, told us that they would like to include physician services if they could, if they were going to start this now. Just noting that it gives them some of that control over that particular spending. All right, so some pros and cons to global budgeting overall. It's very predictable for hospitals. They know exactly what they're getting and they can figure out how they're going to do that. It's especially well suited for hospitals that have populations that are naturally mapped or a very reliable patient population. This can also be enhanced by the use of supplemental pay for performance or other incentive programs. And in fact, as you'll see, the first bullet on the other side, just noting one of the cons, this can encourage an underprovision of services since you receive the same amount no matter what you provide. So it's really kind of essential to pair those with pay for performance and quality measures. Global budgets can involve more financial risk than some hospitals are willing to accept. Because you do get a flat amount, it can be a challenge when unexpected events occur. It can be less responsive to expanded healthcare services. So if you're in a community that's growing rapidly, that's something you would want to be aware of. And a little more difficult to implement in suburban or urban areas that have really overlapping patient service areas because those population factors can change. Next slide. I think one of the big questions everyone has is, do global budgets build cost savings? And the answer is maybe, but there are some good examples demonstrating that they can be used effectively. So again, Maryland, there was a study done, and this was over the first several years that they implemented global budgets. Maryland was matched to out-of-state comparison hospitals over several years, and they found that Maryland hospitals performed quite well in regards to those comparison hospitals. They did see declines in their inpatient and outpatient expenditures, no change in 30-degree admissions. But it did demonstrate that there can absolutely be value to implementing hospital global budgets. On an international level, we know that administrative costs in this country are high, but one study in particular found that U.S. hospital administrative costs are some of the highest that we can find in the world. And in fact, can account for up to 25% of U.S. hospital spending, which is pretty phenomenal. Other nations in the study had hospital administrative costs that were between 12 and 20%, but the big takeaway here is that those nations that use hospital global budgets had the lowest hospital administrative costs, around 12%. So about half of our current hospital administrative costs potentially could be reduced.
Haley, any information on quality and patient care and things like that? Not just on, this is focused on the cost side, but I'm wondering how global budgets and particularly how Maryland looks in terms of quality of care.
Yeah, it's a great question. So you might recall, might not, that's fine, that Maryland global budgets account for 98%. That remaining 2% is based on quality. So that is something that they are monitoring, and based on our conversation with them, their quality measures are good. They're keeping up with other hospitals with respect to that. I don't know that it's exceptional, but it's on track. There's certainly no decrease in quality as a result of them implementing the global budgets.
And we do have Johns Hopkins. Very good. One more minute to finish.
Just to make this a little speedier, we'll combine this, noting there are some implementation challenges, namely data, stakeholder resistance, change is hard, and there is economic volatility. Global budgets can be tricky, but there are solutions to all these things. Having good data systems, engaging parties, and many options around flexible budgeting, including in Maryland. Folks do have an option if there is some kind of event to appeal mid-year and receive changes, which I think is really great. Next slide. And these are just some of my final thoughts, based on the research that I've done. Just noting global budgeting models need to be transparent. Those that have the most trouble implementing global budgets on kind of that international level is because it was deemed sort of a black box, and providers to respond to that. Choosing the right services to include is really important, so namely those specialty physician services. There could be other hospital services. And then also just global budgeting systems have to be continually refreshed, changes in technology, and what's an appropriate site of care. And finally, noting that every place that's implemented global budgets has gone through significant changes. So understanding this is an iterative process, no matter how you do it. Thank you.
Thank you so much, Lee. We have like 1 or 2 minutes for questions. Go ahead, Tim.
First, I'd like to thank you for providing a very comprehensive summary of global budget. I have 2 comments, suggestions. The first one I think is very important. Whenever we analyze a system for its pro and con, it's very important to begin explicitly those pro and con are from whose perspective. So the pros and cons, you summarize that primarily from hospitals with a mix of society. And with that, one important pro has been left out. The strongest argument for global budget is most effective from the societal point of view to control cost inflation. So that's just an example that once you identify from whose perspective, it makes those pro and con more clear. And then second, just a brief comment. In your international comparison, you attributed the global budget with lower administrative costs. That might be a little bit misleading, a little bit, because when you do international comparison, one very important factor is whether the country involved, and I think most of the countries you included, at least in the table, have universal health care. So in terms of hospital administrative costs, universal health care is the dominant factor to reduce the administrative costs. And it will be interesting and helpful to see within universal health care system, which country use global budget, which country does not use global budget. Then you control the universal health care. Otherwise, that comparison with the United States left out the key factor, the universal health system.
Anyone else have questions or points of discussion? Thank you so much, Lee. That was really great. We're going to take a 10-minute break. It is 37, I believe. So we'll come back at 10:47. A little bit, 10-minute break. Thanks. To reconvene now, we're going to get started. Yeah. Are we back on? Okay, welcome back, everyone. We're going to get started here with the second half of our meeting. We're going to start with our committee updates, and I'm going to pass it to Amy to give a update on community engagement. I'm sorry. Thank you.
Okay, this is Amy Fellows, and I'm giving the update and the co-chair of the Community Engagement and Communications Committee, and giving our update on our work. We continue to make strong progress with Cabby Benz, our communications contractor. The committee has been actively reviewing draft materials, and in October we'll be bringing forward to the board 2 one-pagers describing the board's work, one very detailed and kind of wonky, and one in very simple, plain language. A strategic messaging guide and the updated mission statement language for the board to discuss and vote on.
Looking ahead, we're working on a FAQ or frequently asked questions document, a finalized style guide, updated website copy, and new presentation slides that are aligned with the messaging guide for when board members go and communicate, present out in the community. Having met with the board chair and vice chair to begin the conversation about strategic communication support for the board and various committee members. We met with Patty Wentz and Diana Bianco, our community engagement consultant, who is coming back on in October to begin planning for the required community engagement sessions with providers, business leaders, disability-led organizations, and CCOs, etc., which we are mandated to do that work with. We anticipate beginning in January to February 2026, assuming this timeline for the plan design draft has not changed, but I'm wondering if it's after Milliman, it might be March, but we should update on timelines. We completed an update on our community engagement and communications work plan section of the board work plan after the May board strategic planning and our recent meetings with our consultants to update the timelines and deliverables. And we don't have any questions or strong proposals for the board this month. Okay, and so I don't know, are we gonna put up the updated timeline?
Isabel's, or not that, well, she'll share the updated,
Or, I'm sorry,
Yes.
work plan. So, just briefly here, and you all, may have looked at this ahead of time. No major changes, we just kind of, I think we organized a few of the different committees' work plans to be consistent and to update dates based on our current and working knowledge of our interdependencies. So work stream 1 is the community engagement. And it lists the groups that we are required to engage with. And that timeline is July through March, but really we're going to get active in it, I think, in the year. Established community engagement and communications committee, probably that's, so I'm going to through all the tasks. If you want to go to the number, right, oops. Sorry, yeah. For sure too, sorry, communications. And this is the work that we've been doing with Patty Wentz. And I just kind of give you an update on where those items are. So I think that's it, right? So if there's any questions or comments.
So, just to clarify, you're asking us to approve a new work plan for your committee, but there haven't been any substantive changes to your deliverables or to work streams. We just adjusted the timeline and some of the details
Yes.
specified, but no other major changes.
No other major changes.
Okay.
And so are we doing,
Yeah. It's a work plan, yes. Okay. Yeah. So is there a motion to approve this new work plan for the Community Engagement and Communications Committee?
so who's gonna make it?
Is there a second?
Second.
Any discussion? Okay, we'll do a roll call vote.
Ellen Belanca,
Yes.
Chun-Wei Chi,
Yes.
Amy Fellows,
Yes.
Michelle Glass is absent, Bruce Goldberg,
Yes.
Judy Richardson,
Yes.
Cheryl Ramirez,
Yes.
Mary Lou Heinrich.
Yes.
Thank you.
Great, so much, Amy. Next is finance and revenue. Oh, sorry, Mary Lou, sorry, this is your.
Sorry for that. My question is back on, is there a plan on how, like, lawyers and healthcare providers at all levels? And so is that being worked on, how you're recruiting people to that?
we had put Artemis Consulting, Diana Bianco's work on pause because of
Yes.
our timelines, and she's coming back on in October, and that's when we will get focused on who those people are and those things.
Another question, if we had large or small employers that have, somehow bumped into us or whatever, and I'm saying you're gonna have an opportunity. Is there a way that we can refer them to Diana or to Artemis or something?
I would, you can send Michelle Glass and I, co-chairs of the CCC, your recommendations and we'll work with Diana.
Great. Now, finance and revenue.
Hi, everybody. Cheryl Ramirez, I'm the chair of the Finance and Revenue Committee. Ooh, there's a very bad echo. I want to just first say that the Wi-Fi is pretty unstable here. So if I freeze, I'll count on Mimi to pick up where I left off and I'll join as soon as I can. Secondly, I'm going to count on, or I may have to phone a friend. I see that Morgan and Richard are online and they're co-hosts, so please chime in if we get a question on a very granular issue that I cannot answer. So with that, I wanted to just give a very brief overview of what I consider the bones of a core revenue straw proposal that we settled on at our last meeting this past Tuesday, the 16th. We used a fist to 5 as an indication for support for the major components of the straw proposal. So our goal is to finalize a core revenue straw proposal at our next committee meeting, which is on the 7th of October, for board review on the 16th of October. And we're hoping to get good feedback, questions, some advice for further direction at that meeting. So with that, could you show the slides and I'll go through those quickly.
Yes, they're up, Cheryl.
Okay, thank you. So first of all, our North Star is that we come up with an equitable, sustainable, universal, publicly administered healthcare system by redirecting and restructuring the current healthcare spending, not by increasing net financial obligations. And so the foundation, next slide, the foundation is built on replacing our existing employer-sponsored health spending with payroll and business taxes. And I'm not going to go into, as I said, granular detail, but if you do have specific questions, please interrupt me and we're happy to answer. And I would say by we, probably Morgan and Richard, because they worked on the details of this, this straw proposal. So as you can see here, 100% of the personal income tax is a credit for employees so that there's no double taxation of wages. The personal income tax has exemptions for people who are under the federal poverty level. And I think we have another slide that goes into a bit more detail. And then there are credits and caps to ensure equity. We talk about premiums, and I may need to have someone explain what we mean by premiums. We see this as a tax increment. It's not like the premiums you currently pay for health insurance. And then we did consider additional taxes. So in our straw proposal, we're including a lodging tax for visitors or focused on visitors to Oregon, and then consumption taxes like cigarettes, marijuana, beer, and wine. We did consider sales tax and value-added tax, but ultimately we didn't include these taxes in our proposal. Next slide. A couple of specific details that we embedded in the proposal is that we believe that the administrative savings was a bit low at 4%. And so we increased the administrative savings estimate to 8%, saving $1.5 billion annually. We also estimated the employer payroll tax that would replace the employer-sponsored insurance contributions to be about 11.7%. There's a range in there. That's just an estimate. And then this is on wages above a certain threshold to exempt small businesses. And then, like I mentioned before, wages paid to workers earning below the 100% federal poverty level would be excluded. Next slide. Individual contributions, so 100% of the Oregon Healthcare personal income tax credit would offset the employer's payroll tax. I have to remember the acronyms to prevent the double taxation of employee earnings. I mentioned that before. And we have a two-part structure that combines a new healthcare personal income tax. We're calling that HCPIT on income that's above 138% of federal poverty level. And again, going back to this premium, we would phase that in at 300% federal poverty level, and it's capped at $3,000 per adult. And then, as I've mentioned, we added in some business and consumption taxes, a very modest increase in corporate income tax and corporate activities tax, and then those consumption taxes and a lodging tax. Next slide. So just to summarize, we aim to reallocate the spending, limit new financial obligations. We're trying to protect low and middle income households through the income-based thresholds and credits, and ensure a broad-based, predictable contribution from employers and individuals. And we will certainly refine this revenue framework and do some stress testing through modeling and stakeholder engagement. We're going to heavily rely on our communications committee for that, and just to consider, further options. So that's my report on kind of a preview of the straw proposal. It will probably look similar. By the way, with our straw proposal, we will have a side-by-side comparison of how healthcare is funded now versus what we're proposing, so you can just see it, on one page. And so with that, I would invite Mimi to add anything else that I may have missed. And if you have questions, again, I would invite Morgan and Richard to come off of mute and answer, or potentially describe components in more detail if you'd like.
I think, Cheryl, you did a terrific job, and I think probably taking questions now first would be great. I know Bruce has one.
I was just confused at the personal income tax and premium. Are we asking individuals to have both a personal income tax that's income related as well as a premium? Understanding, I know from Chumley that a premium is a tax, but I think some of this is how you talk about it. So are we talking about two separate taxes to individuals?
Yes, after a certain income threshold, but I'm going to toss it to Morgan or Richard.
Yeah, I can jump in.
Thanks, Morgan.
Cheryl. Just to reiterate what Cheryl said, the first incidence of the tax is to sort of mimic current ESI payments through a payroll tax, but that payroll tax is used as a tax expenditure that is credited to employees as part of their personal income tax. So the best way to think about this is the main source of funding will come from individuals using the healthcare system. And the way we distribute that funding need is through their submissions of the personal income tax through an actual marginal rate for taxes that has sort of exemptions and offsets, and also through what we're calling basically a healthcare personal premium tax. And the reason that we think about them in this sort of dual nature is we can, one of the key principles of the committee is to try to design a system that is both fair and equitable. And particularly on the equity side, administering it through a marginal tax rate on the income tax side allows us to adjust funding of the program on the basis of income. But it's also important that we also acknowledge that individuals use healthcare and that households typically have more than one individual in them. And so the personal premium part is meant to sort of account for the fact that there are sort of multiple individuals and that folks have stake in paying for that on that basis. And as Cheryl said, they're looking at certain ways to also then adjust for income measures, right, by not sort of exempting individuals at a certain income threshold from being responsible for paying some of those personal premiums.
It all sounds great technically from a political standpoint. I just wonder the ability to have people support what are 3, 4, 5, 6 different taxes is, I think, an issue for all of us to discuss. And, we do have a system where all of us over 65 do pay an income related premium. And we're used to that. And so I would just point that out. I understand technically all of this. I'd love to see the examples of how it will affect different individuals and different households, et cetera. But I just do have some concerns about the perfect being the enemy of the good, so to speak.
Yeah.
It all sounds great technically, but politically, I just have some questions.
Thanks, Bruce. A couple things I wanted to say on that. So the side-by-side analysis of how we're currently paying for healthcare and our proposal will be helpful, I believe. We're in early talks on the calculator that would show both individual and employer payments, how that would change. So we're just barely starting to talk about that. And then again, I do think we're going to have to be in close communication with our communications committee to get help on relaying that message clearly.
And Chun-Wei has a question.
Yes, actually following up on Bruce's current questions. Regarding the premium,
Yes.
from our perspective, it has pro and cons. The pro is to kind of mislead the public that this is not a tax. But the con is among the public or critiques or opponent of universal healthcare, they will quickly point out this is a tax. So there's a pro and con on whether we want to label it as premium. But I also have questions to reduce confusion and simplify the taxation. It might be feasible just to fold it into one single personal income tax. You just grade it progressively. And rather than separate that and call it something else, that's confusion and misleading. So that's something to consider. And also to avoid unnecessary criticism and confusion, I think in the communication stage, it will be very important to clearly, explicitly state it. The payroll tax is levied only at the employer, not at the individual. Otherwise, people will be confused. We are not being double taxing.
Very good points, Chun-Wei. I wonder, Morgan and/or Richard, do you want to speak to this idea that we fold it into one personal income tax as opposed to a separate healthcare personal income tax?
I would say that is likely the case with Chun-Wei articulated in the end, is that you operationalize this as part of your tax return when you file it with the state of Oregon, and your payment is really a component of really a marginal tax rate and a sort of almost like a head tax a bit in the computation. But perhaps we just talk about it as one tax, and then in the details, the computation of that has that sort of dual nature.
Thanks,
Can I
Morgan.
just ask one more about that, Morgan? So if I understand that right too, that if you have a household with 2 adults and one's working and one's not, it's the working adult that's paying the income tax, but then this premium would be up to $3,000 for both the adults in the house. So the household would have the income tax plus $6,000, whereas if you had a household where there's just one person, they would pay the income tax of $3,000. So it's a way of paying for people who aren't working. Is that right?
Yeah, they're using the system, but not necessarily drawing income. And so the way it would work, right, you would just enter in your information on income, number of exemptions, right, number of people in your household. And then from there, right, we can provide a number of deductions and exemptions to compute your tax.
Yeah. Yeah, so it still is, it's a cost to people who right now, if they're not working, could qualify for OHP, which is a no-cost version of healthcare.
Correct.
That was one comment. And so to keep that in mind, but then also you started the personal income tax at 138% of federal poverty level. And currently Oregonians qualify for Oregon Health Plan up to 200% of federal poverty level. So there are folks who currently would get OHP who would now have a tax in order to get their healthcare.
Yes, I think this remains a place of conversation for the committee, is sort of where to set that threshold. So appreciate that note.
Yeah, and then one other thing, the credit for the payroll tax that goes to the individuals, that's a true credit, right? Yes. So it's just a deduction of their taxable income. It's not, they wouldn't actually that amount.
It's not a deduction, it's a credit. So deductions work a little differently. And so the credit is just like a straight credit against your tax due.
Right, so but it reduces your taxable income as opposed to.
It reduces your tax liability, not your taxable income.
Okay, it reduces your tax, okay.
Any other questions?
One thing, Cheryl.
Hey, could I just say a couple of, oh, sorry, I didn't hear. What was our question?
I'm sorry, I'm disputing myself. I'm not technologically too good here. The one thing that wasn't brought up in this, and it's not been fully figured out yet, but talking about Medicare and how what people in Medicare are currently paying, and how to deal with all of that is an issue that we need to continue to discuss.
Yes, definitely. Since we're still talking about that in our committee, we decided not to open that up today, but if anyone has a specific question, I'm going to punt that to Morgan too.
And I will just say yes to Cheryl's question.
Yeah, you're considering how to work around the Medicare issues, or we've already paid into the systems. Yeah.
Along those lines, are we then assuming, put aside for a minute operationally how, but are we assuming we're capturing the Medicare IRMA dollars that flow into the system?
Actually, we can do it either way. Because if we are capturing the Medicare, particularly Part A and Part B dollars, then we are integrating that into all our systems. So that increase our revenue, but also increase our expenditure. If we do not capture Medicare funding, we reduce revenue, but also reduce expenditure, because for the Medicare beneficiary, their coverage on Part A and potentially Part B will not be part of the universal healthcare. It will be a separate part of money.
Right, but I thought we were assuming we're including Medicare.
And they don't have control of that,
right?
Yeah.
But if we do, the question will be, now our seniors paying 3 different taxes, an income tax, a premium tax, and an IRMA, which is a premium tax. So I'm just trying to get clear on what this scheme would do to those over 65.
And that will be a very contentious issue because those who are Medicare beneficiary, they already contributed through their lifetime. And we have to
Bruce,
factor that in.
we did start addressing that very issue. Morgan, I don't know if you want to speak to one option we came up with at this point, but I'll leave that to you.
Yeah, I think it's probably a little premature. I'll just say like this has been a question front and center, and I would say the assumption right now is that we get both the necessary Medicare and Medicaid waivers that we can capture that spending. But as Chunny Wei said, right, there is also an implication on the sort of plan design and benefit part of that question that will change both the cost of the program as well as what the funding gap will be. And so one of the things we're trying to make sure is to sort of understand the deductibility of Medicare premiums that are paid on individuals, so that whatever tax they do pay accounts for the fact that they are already making payments and not being double counted.
Thanks, Morgan. And I think we've probably gone over our time, so we'll end there.
That's okay. We'll hear that.
Thank
Thank you, Cheryl. And as a reminder, there's obviously no straw proposal for that, but we anticipate that in October. Okay. For plan design and expenditure, I remain the interim chair. We're working on that. But plan design has had a series of robust discussions lately. We also have no straw proposals today. At our last meeting, we spent quite a bit of time with our Milliman consultants. As you know, because they have the actuarial expertise, they're going to be working closely with Plan Design and Expenditures Committee on how the benefits and enrollment and eligibility play out under different models. And so we had a lengthy discussion with them, which was really great. We then had a presentation from Lee Hastings, our policy analyst, on emergency transportation and how that works in Oregon, which was fascinating, and is a really interesting thing for our committee to consider. Emergency transportation is paid for through a combination of healthcare dollars and community dollars from counties or rural districts, and so how that would be covered under the universal health plan is very interesting. And we had breakout groups to allow our committee to focus on areas of interest. The breakout groups talked more in depth about transportation issues, a quality strategy for the universal health plan, and then hospital payments based on this presentation from previously. So we are working on refining those ideas, and we anticipate that we will soon have a quality strategy straw proposal for the board to consider. That's all I have. Yes, Amy.
I think previously you talked about a long-term care work group, and I'm wondering what's happening with that.
Yeah, thanks for bringing that up again. The committee asked for a separate group to be convened by this board to discuss long-term services and supports. And when that issue was raised, we were in the midst of our staffing transitions, and we were not able to make that happen at the time. So we're still working out the best way to go forward with that. But we are anticipating a small separate group, possibly using some of our plan design members, possibly recruiting from the community. We really want experts on that group. There's a lot of us who are interested in that and want to see it function well, but don't have the expertise to contribute meaningfully to that. And so, but yes, we need to pursue that in the next 2 months or so.
And I would just encourage us to make sure somebody from the disability community and understanding the role and community Medicaid benefit and how that will play out in this. So without that institutionalized, and there's a big push for that federal level right now.
Any other questions? Great. Operations.
That'd be me. At our operations committee, we updated our work plan, which was really just extending the due date out to February 26th. But we did add one key piece of work that I think people are going to be interested in to the operations committee, which is we started to discuss what functions would be potentially regional and what functions would potentially be central. Again, we're not taking on whether we should have 1, 5, 10, 20, 30 different regions. We're not talking about any of that, but we are talking about what functions would be regional and what would be central. We're just beginning that, and we'll come back with a straw person proposal to the group probably in a couple of months. And other than that, we had some presentations from our Millman folks about just how we're going to look at the operations work. And you heard some of that today, and had someone from PEP talk to us about how they administer their self-insured benefit to give us a sense of what that might look like. So with that, I will entertain any questions.
Get an approval on the updated operations work plans.
Right. Yeah, so just like with Amy, so the changes that you made to the work plan, just to reiterate, are you just adjusted the timelines to reflect what's going on, and then added a task around defining regional versus central functions of the original plan. Is that right? Okay, so is there a motion to approve the new operations work plan?
Move to approve as presented.
A second. Any discussion? Okay, roll call vote.
Helen Blanca,
Yes.
Chun-Wei Chi,
Yes.
Amy Fellows,
Yes.
Michelle Glass is absent, Bruce Goldberg,
Yes.
Judy Richardson,
Yes.
Cheryl Ramirez,
Yes.
Mary Lou Hunter.
Yes.
Great, thank you. And I'll just express gratitude to the operations committee for taking on that regional entity concern. That's very helpful. We appreciate it. Okay, I think that covers all our committees, and we're at 11:30. Great. So I'll pass back to Lee for a presentation on federal and state health policy update and its impacts in Oregon. And I think 20 minutes. Yeah, 15 minutes. 15 minutes should be good.
Okay. So I'm going to talk a little quickly, skip over some of the details of these slides. I was asked to present a little bit about the estimated impacts of to Medicaid and market change, given Medicaid and marketplace, excuse me, given all of the changes that we're seeing at the federal level. So just as a quick overview, when it comes to Medicaid, a couple really big ones that we've got our eye on, new Medicaid work requirements coming into play, and reduced federal funding for those caps on provider taxes, which are going to take effect in a couple of years here. With respect to the marketplace, we're looking at the expiration of certain premium tax credits at the end of this year, as well as what I refer to as a number of technical changes to open enrollment. Next slide, please. So these are some of the federal estimates done from KFF here, looking at what could happen in the next 10 years. So this is estimating what they think would happen by 2034. So just keep in mind, these are long-term projections, but they do provide us some level of, what the impact could potentially be. It is estimated in Oregon that approximately 210,000 people, or 5% of Oregonians, would lose health insurance coverage due to those combination of policy changes. And that is quite a range, actually going between 160 and 260. You'll note from the map on the side, Oregon is one of the higher states to be losing coverage, and that would actually be because we've done such a good job of expanding healthcare. We have so many people covered. We do have more people at risk with these federal changes. Next slide. Now, looking at these specific groups of folks that are potentially going to be losing coverage, we have some losing coverage due to Medicaid changes, others because of these upcoming changes to the marketplace. And then there's this kind of group of people that are sort of somewhere in between the Medicaid and the marketplace that just due to these policy interactions, we can anticipate lose coverage. And again, when I say lose coverage here, I'm assuming no changes at the state level, just to be clear. But we have those estimated numbers, and just hypothetically, if we wanted to continue to cover these folks, and I base this off of what the current CCO capitation rate is, it would be somewhere between 1 billion and 1.65 billion to maintain coverage for this group of individuals. Slide. All right, so those Medicaid changes pretty easy to understand. It's mostly a loss of federal funding. The marketplace, it's a little bit more nuanced. So under the ACA, eligible individuals could potentially qualify for a premium tax credit to reduce what they had to pay in terms of their monthly premium. Now, initially, this was only available to folks with modified adjusted gross income from 100 to 400% of the federal poverty guidelines. During the COVID-19 public health emergency, this was actually expanded to anybody. So even if you had an income greater than 400% of the federal poverty level, if the cost of the benchmark silver plan exceeded 8.5% of your income, you would get the remaining amount in a premium tax credit. So essentially a cap on the percentage of your income that you could possibly pay towards health insurance. You can only pay up to 8.5% of your income on health insurance. Slide please, great. So you can see from this table, it's a little small, but I'll trust that whenever you take a look at these slides, when I'm not speaking quite so quickly, you can really get the nuance of it. But the key takeaway is that these percentages are increasing. So what these percentages represent, again, is that cap on your income. You can spend up to this much percent of your income on health insurance, and the rest would be covered by a premium tax credit. Those amounts are all going up. So reduced credit amounts, those over 400%, there is now no cap on how much of your income could go towards your health insurance. There's going to be some changes regarding needing to repay advanced premium tax credits based upon a truing up of income. And premium tax credits will no longer be available to lawfully permanent residents as well. So regardless of income. Next slide. So the impact of these reduced premium tax credits is pretty significant. Now these are from the CBO, so they are national numbers, but stating that in the first year alone, that would be 2.2 million folks that would lose health insurance, going up to approximately 3.7 million and kind of remaining in that high 3 millions. Now what's important to note about these folks that would be potentially losing health insurance is that these are most likely to be healthy individuals. Which is not a good thing for health insurance markets and stability of premiums. So as follows, they're estimating that benchmark premiums could increase by over 4%, and then in the high 7% for years thereafter. And a lot of this would be due to the fact that healthy folks who are finding these premiums too expensive would rather drop their health insurance than have to, potentially pay 10, 15% of their income. So the expiration of these enhanced premium tax credits will raise out-of-pocket premiums by over 75% on average. And this is a combination of premiums going up and then a greater percentage of your income being required to be paid towards those total amounts. Now, when it comes to the organ marketplace, we have about 140,000 individuals currently on the market. Of those, about 80% receive premium tax credits. Those premium tax credits are about, on average, $531, and the amount of premium typically paid by those individuals that receive premium tax credit is about $272. So as you can see, for folks that are on the marketplace getting these premium tax credits, those premium tax credits are covering, let's say about 2/3 of the premium, and that would change pretty significantly. Individuals who purchase coverage through the organ marketplace are predominantly, as we tend to see across the nation, those healthier individuals. A lot of lawfully present immigrants, self-employed entrepreneurs, part-time workers, and employees of smaller folks that don't offer health insurance. So these are the kind of people, again, that you really want in your risk pool. They're generally employed, they're generally on the healthier side, and they can help distribute risk a little more evenly. Next slide. Now, here are those various technical changes that I referred to. First and foremost, plans will no longer automatically renew. So previously, if you were on the marketplace and you did nothing, you would continue on if you did nothing during your open enrollment. For our current plan year, 2025, approximately 29% of the Oregon marketplace enrollees were auto-renewed. So pretty significant numbers have been able to take advantage of that. Additionally, there will be changes with respect to needing to update information around income, immigration status, and other details for visa coverage. The open enrollment period has also been shortened by a month. It is not long to begin with. For the current plan year, nationwide, 40% of people signed up after December 15th. So 40% of folks signed up in that last month. And then finally, new enrollees will need to prove eligibility before receiving any premium subsidies. So previously, we got sort of a 90-day grace period during that application, but now that will no longer be available. And again, a lot of these changes really just designed to get people out of the marketplace, essentially. If you fail to realize that the enrollment period ends too soon, or that now you need to go in and manually renew, you're going to be out of health insurance for the following year. All of this leading to what I term a perfect storm for premium increases. That is indeed what we are seeing. So this federal legislation will lead to a sicker insured population. And there's quite a bit of financial uncertainty in this country right now. I think it's impossible to avoid some of the headlines, but with concern about tariffs and how that's going to impact a whole number of industries, we're seeing really substantial rate increases. So there was an analysis done of initial rate filings for marketplace plans across the country, and the median proposed increase was 18%. And last year it was 7%, which was already on the higher side, but we're talking an increase that's almost 3 times that. Now in Oregon, we can consider ourselves lucky that we're only looking at a 9.7% increase. Our friends up in Washington noted that they are going to see a 21% increase in their marketplace premiums. And then we even do have some this particular quote on the side, just noting the impact of overall financial uncertainty that United Healthcare of Oregon went ahead and just added a 2.2% bump to premiums just based on some of that. And that's without having to be concerned about having a sicker population and some of the other impacts of these various changes.
It's just the individual market, it's actually higher in the small group.
Yes, this is just the individual market. That is correct. Small groups are really going to feel the pinch. So just to recap here, changes in Medicaid estimated to result in a loss of coverage of a little less than 200,000 people by 2034. Based on current capitation rates, this would be an average of $1.2 billion to maintain Medicaid coverage for that group. And then those other policy changes to marketplace operations could result in about another 20,000 losing health insurance. Fully subsidizing that population to remain in the marketplace would cost a little less than $200 million based on those current marketplace premiums.
Questions for Lee? Any questions for Lee or any discussion on this topic? It's pretty well.
Well, thank you for this helpful projections and summaries. Well, the marketplace was very green. I think for the public engagement, this will be a positive point for us to promote universal.
Yeah, our report, which is due as a reminder in 1 year, will be landing, I think, at a very opportune time because this is when all of these changes will be really start. We really appreciate the presentation, and it clarified for me something that I couldn't reconcile before, but the way you said it was not only are the premiums going up by 10%, which alone would push a bunch of healthy people off the market just with the 10% increase in the premium, but then then the proportion of their premium that is covered by the subsidies is also going down at the same time. So they're going to see like a really dramatic increase in premiums far beyond 10%. So other questions, comments? Okay, let's move on the agenda. Next steps. Any opportunities for outreach or any presentations that have been done from the agenda?
Yeah. Over the summer, I have done two presentations, both the international conferences, and I have been trying to promote our effort Oregon Universal Health Plan. Not only some people even in Oregon didn't know, there are a lot of people in the United States and outside of the United States. So whenever I have opportunity, I always emphasize this is what we are doing. And just this past Tuesday, I was invited for an international webinar again on the topic of universal healthcare. Again, I emphasize that both Oregon and Washington are taking the initiative. Also, yesterday, actually today, we were forward to our board members. We discussed about in November, I will be invited to the 30th anniversary National Health Research Institute, that's Taiwan's equivalent of NIH. So to celebrate 30th anniversary for international conference. They have a big focus on universal healthcare, so they invited me to give a talk. And there's back-to-back two international conferences. 2 days before that conference, there's a Taiwan's Ministry of Health Global Health Forum. The 2-day conference, the first day are entirely on universal healthcare. And they invited my advisor. It's been decade I haven't seen him. They invited my advisor, Bill Xiao, to give a talk about universal healthcare, together with other experts from UK and from Germany, from Japan, and from other countries. So I thought that's a great opportunity if you're interested in participating in these two back-to-back international conferences. And you get to hear those top international scholars you seldom have the opportunity to hear. And so maybe we'll send out the detailed schedules. Also, one more, Healthcare for All Oregon is planning sometime in October to have a webinar to talk about Taiwan's universal healthcare. This year is their 30th anniversary. So they invited me and one more member, my former PhD student, Rebecca Xu, and the Deputy Director of Taiwan's National Health Insurance to talk about its achievement and challenges. The time is not determined yet, but they will announce.
Thanks so much. That's great. Judy and I were invited to give a talk to the OHSU Alumni Association, which we did recently. There were about 200 folks there, clinicians and retirees from OHSU. So that was really great to be able to talk to them and give them an update on our work and sort of get a snippet of their concerns in the Q&A section. So yeah, that was great. Anyone else have invitations or presentations?
The Healthcare for All Oregon is having our annual garden party on Saturday. And both Bruce and I, it's going to be very brief, but just updating people on the fact that we're working on it and getting them to try to hopefully dial in, watch, become part of input, etc.
Anyone else? Okay, any requests for the staff about future topics or things you would like us to dig more into in our board meetings? This is your chance to influence the agenda of the next few meetings. Yes, Amy.
Mine, I think, is maybe less of a board meeting, but I was still percolating on Lee's presentation and then diving into the Norman presentation. And I'm wondering if in some of the analysis, like, do we have an idea about how many people are 1099 independent contractor types who are also, like myself, often getting our insurance through the ECA plans, and just kind of having a better idea about those numbers, and then also kind of better understanding how the tax aspect works for people who may not have a
employer taking taxes out for us.
Yes, John.
And one area myself and the whole member might be interested for staff to organize information is Canada. Two aspects. One is how did Canada transition from identical healthcare system like US to universal healthcare in 1971? And how does that transition affect the impact? That would be a good lesson for us. And the second part, more relevant, more recent is let's pick our neighbors, BC, because Canada's universal healthcare is administered by provincial government. So to have information about how the provincial government of BC administered their universal healthcare in that province, that will be helpful guideline for us.
I just want to add on to Amy's. In terms of the revenue plan, I heard that there'll be a comparison between how we pay for care today and how we would pay in the future. But I think it'd be really helpful to have 6, 7, 8 different scenarios. Family of 4 at 100% at who make $100,000, a 70-year-old makes $50,000 as a Social Security benefit of $30,000. You know, a healthy 28-year-old and who works at Nike. Yeah, you can come up with a variety. Some, people that pay for insurance themselves, people that get it through work, people at different ages, people at different incomes. And I think that's how we have to start to look at things, because whatever the revenue plan is, it's not going to affect everybody the same. I think it's really important to understand those issues, and with some granularity. I think it's going to take some work looking at those 8, 10, 12 different scenarios and how that will affect.
It started with 6, now 8, 10.
I think that the Revenue and Finance Committee and Morgan can speak to that. That is the plan, but we have to get first kind of like, how are we gonna, how are we gonna tax people and those, and then we can do that, but that's kind of coming. Yeah. We definitely said we need to.
So I want to point out that we have 3 pretty big discussions lined up for October. So the Community Engagement Communications Committee is going to be talking to us about our strategic communications and our revised mission statement, and that'll be a straw proposal to Finance and Revenue is going to present their straw proposal for our revenue strategy, and I imagine there will be a lot of discussion around that. And then potentially plan design will have a quality strategy for the UHP. So, and then operations, probably not October, but maybe November, talking about the role of regions versus state. And so we will endeavor, as we always do, to get materials out to you in advance. Sometimes that's possible, sometimes it's not. But I would say for the next meeting in October, it's going to be absolutely imperative that we will get those straw proposals out to you at least a week in advance. And I'll ask all the board members to really take some time, particularly with the revenue strategy, to review it in advance, make list your questions, go over the materials from CECC about our strategic communications, and then we'll have extra time at next meeting focused on our committee work because of there's going to be a whole bunch of proposals coming to our next meeting. Okay.
I had a question asked by some people asked me, is there kind of something in our rules, bylaws, whatever, that says that we only have one board meeting a month? I mean, will we later be, these are big issues and have a lot of discussion, and I don't know.
No, there's nothing that says we
that we had to, so it may be at some point that we'll have to, kind of like Revenue and Finance, kind of have a second meeting sometimes or something.
We've already done that once when we were hiring our new executive director. We had a special meeting of the boards. So yeah, so we can call a special meeting of the board if we feel that that we need additional discussion.
Yeah, that's what I said to somebody, but I wanted to make sure.
Yes.
Thank you.
Any other thoughts or considerations for the agenda? Okay, I believe we have some public comments. I'll hand it to Isabel. So take that.
Yes, so as always, we're super grateful to members of the public who provide public comment. And people can submit written public comment at any time via our website. And we ask that to be included in the meeting materials, we submit those 72 hours in advance. And if it's after that point, we'll just include it in the next meeting. And for oral public comment, we ask to sign up either 24 hours in advance online or in person to sign up. And unless there were any people that came in after the break that signed up for public comment, we have 2 online commenters today. Those comments will be timed and we ask people to stick to around 2 minutes. So our first person is Melanie. Pull up the timer and then Melanie, you should be able to unmute and give your comment.
Hi, this is Melanie. I'm having a really hard time hearing people who are in the room. So I don't know if somebody was talking about how to give public testimony.
Yes, I was just giving generic instructions, but Melanie, we are ready for your comment.
I didn't catch what you said. It's really hard to hear through the mic setup in the room.
Melanie, can you hear me okay?
Yes, I hear you better.
Okay, so Isabel was just saying that you can go ahead with your comment and please restrict your comments to 2 minutes. We have a timer on the screen for you, but go ahead, the stage is yours.
Okay, thank you. Well, my name is Melanie Bobbitt, and I thank you for the opportunity to give testimony today. I'm a social worker and have spent my career working in healthcare. I'm currently an independent contractor for a local nonprofit organization that assists local musicians when experiencing serious health conditions and related financial hardship. We exist entirely because of how this population of typically self-employed people are uniquely impacted by gaps in our social systems, including unstable access to health coverage and care. For 12 years until my resignation in 2024, I worked at one of Oregon's largest hospital and clinic systems. I started out as a Medicaid specialist, hounding uninsured ER patients about their lack of coverage and Medicaid applications when they were lucky enough to qualify. I then moved on to my work as an oncology financial counselor, a position created to be the point person on patients' care team to do damage control on the financial and insurance disasters caused by our broken system while they endured life-threatening illness. I could spend hours telling the heartbreaking patient stories I experienced over my 5 years in that job. Many of those stories ended with patients dying under financial distress caused by our broken insurance system. And many stories involved the punishing practices of the very hospital I was working for. I, to this day, wonder how I wasn't fired for many times getting into shouting matches with my own leadership about the way that we approached insurance-related challenges that our patients ran into while getting cancer care. Along with that type of demoralization that eventually ran me out of that job, I also directly saw the administrative waste in this system. Within that department, which supported only a handful of the health system's specialty practices, I was among about 40 employees there solely to deal with the endlessly shifting prior authorization requirements of private insurance companies, a handful of managers and directors making 6 figures apiece, and my high salary too, which I would have given up in a heartbeat if we could have a way to do away with it all. After moving on to another position, I resigned from the hospital just over a year ago when I could no longer take the effects of our imploding healthcare system on patients and myself as an employee. Since losing that employer coverage, I'm on OHP. I love this coverage and the relative ease I have accessing care. My experience is far smoother than the periodic nightmares I endured on my employer plan, like leveraging my HR department to fight out-of-network ambulance and ER bills. My 2 children, however, were on my employer plan and are not eligible for OHP or a marketplace subsidy due to their father's income. He's a small, Yep.
Sorry to interrupt, your 2 minutes have expired. I wonder if you had a question or a comment for us.
Oh, shoot. Sorry, I threw this together and didn't time myself. I have a lot more to say. I have a lot to say about what I'm dealing with right now on my child's off marketplace plan and the classic in or out of network debacle. But I can just wrap it up and say that I think I have a lot of personal and professional perspective that I would love to offer UHPGB in any way it could help make universal health coverage happen.
We would really appreciate hearing about that. You are more than welcome to submit public written comment through our website. You can submit as long as written comment is.
I'll send everything else I had written up that way.
Okay.
And thanks for your continued advocacy.
What we're hearing to say here, the next person for public comment is Colin.
Okay, next we have Colin.
Hi, can you folks see and hear me?
Yes.
Yes, great. Hi, my name is Colin Stackhouse. I work as an independent contractor with Healthcare for All Oregon. You guys are familiar with our work, and some of you are also members of our organization. I'm grateful to have 2 minutes to sort of talk to you. And sort of in the spirit of more is more, there's a couple things that I want to talk about, and we need many more people submitting comment all the time. As far as like the kind of consistent technical difficulties, I have been listening on my phone for this meeting, and it's just like all the other meetings, like close to impossible to understand what people are saying. I mean, it is legible, but it's like trying to like swim through mud to try to understand the words you're saying, and maybe some sort of change in technology could be useful. So that's just one comment. I think I mentioned in my request to give testimony about that I want to talk about power, and I'm preaching to the choir. You guys know so many of the details of the challenges of this system, but phrasing it in a way, I'd like to continue leaning into the opportunity to remind people that our current system is one with hardly any power for Oregonians, and the goal of this group is to bring some power to us, right? So the people and the patients actually have a little bit of power in this new system. And finally, I want to comment on some of the stuff that we've seen from the subcontractor Milliman. I really appreciate their work and their expertise, and I'm really looking forward to some of the details that they're able to contribute. But some of them have worked for private insurance companies, and the only way to like understand how payers work is to work with payers, but they have a history of being complicit in working with insurance companies that have been, benefiting from our broken system. So I'm grateful for their work, and I need to comment that it's hard to trust them because they've proven themselves to be, perpetuating a system of harm in the past. But I hope that they can continue to listen to their morals going forward. Thank you.
Thanks, Colin. Okay, great. Thank you all. I'm going to pass it to Amy for our reflection.
Oh.
Oh, you signed up? Oh. Sorry, we have one more person for public comment. Please introduce yourself and then keep it under 2 minutes. No.
Push the button so it's reading.
Oh, can you hear me now?
Yes.
Okay. Thank you again for all the work that you've been doing and for hearing the public comment. I agree with the comments about the audio. I think the owl loves to be close to people. So if we can compress ourselves to within 8 feet of the owl, I think we'll do better for people online. Mike Huntington, by the way, I'm a retired radiation oncologist. First thing I was going to say is that when we hear the word market or marketplace, we're not going to get it out of the vernacular, but can we in our brains say patient population? Market means a vendor selling goods to somebody only if they can afford it. So it's kind of the wrong starting point to say market. Thank you for using the microphones like this. For those of us in the audience, this is much better. The in-person audience. I would like to emphasize also that fee-for-service is not by itself the cause of high costs. Other countries use fee-for-service in a rational way. Those are the same countries that pay half of what we do and have better outcomes. I'd like you to listen to Steve Campbell, by the way, from Hawaii, and his version of a good fee-for-service system. And then finally, with global budgets, I understand that you can have global budgets for operations that are separate from global budgets for capital. In our current system, mixing the two together kind of contaminates the budget. Doug Boyson, former CEO of Samaritan Health Services, endorsed global budgets. He wanted to get off of the hamster wheel, as he called it, of processing 70,000 codes. Thank you for your attention.
Thank you so much, Matt. Okay, great. Now I'll pass to Amy for final reflection.
All right, thank you so much. Just want to move one slide forward. So every day I'm grateful and humbled by the work that everyone who is on this board and all the committees and the people who come to the meetings and the people who attend virtually because they are showing an act of service. And I love this quote from US Congresswoman Shirley Chisholm, which service is the rent that you pay for room on this earth. That speaks to me, but also again speaks to the gratitude that I have for you all for all the work that you're doing. And of course, shout out to my wonderful staff too. So,
thanks, Amy. That was great. Do we have a volunteer to do a reflection for our next meeting?
I will, if you remind me.
Okay. Okay. Thanks. Okay. And with that, this meeting is adjourned. Thank you all so much for your time.
Bye, everyone. Thank you.
We forgot to have